Thank you so much. It's a real pleasure to be here. Thanks so much for having me, and especially it's an honor to close the healthcare session of AI4 conference. And I want to really thank everyone who's actually stayed here till the last session, and really appreciate your support and your participation. That's why let's make it interactive. Please feel free to ask any questions you have, and even I'll be stopping during my talk because we have time, right? We can stay here till 4, 5, 6 p.m. No, just kidding, yeah. Of course, we need to make it to reception. That's why let's have an interactive session, and if you need more time, we can talk more at the reception with a nice pint or two. And here again, I have to start with a standard disclaimer that it's my personal view, but not the employee organization. And the topic of today's discussion, I would say it's slightly different from what we saw before at the conference. If you remember, most of the talks about success of AI, I'm going to talk about failure. When, in what cases, AI really fails and why. But to sweeten the pill, I also will give you a solution, how we can overcome the obstacles, how we can solve the problem, how we can do AI and HI, human intelligence, together, and why we need to do that. But first, I'll start with the challenges, with the data to predict disease progression. You might ask me why we are talking about disease progression. First of all, again, in healthcare, in pharma, it's extremely important to understand if patient is ready to progress to the, let's say, oncology from stage 3 to stage 4, in lung cancer, in the breast cancer, in ovarian, in hematology. There are also disease progressions going from the first line of therapy to the next lines. I've been doing research in this area, trying to predict progressions for last, I would say, over 20 years. And in some sense, this is kind of aggregation of that research, multiple publication in American Journal of Clinical Oncology, of the thoracic oncology, and so on and so forth. Plus, been doing rare diseases over the last few years. It's a similar challenge. How we can see patient progression within the rare disease that patient actually now needs a special therapy or medication. And I'll start with the data, and we'll talk about missing claims, missing data to missing indicators, and that we actually need to predict data separately from predicting the patient progression. Basically, here I'm talking about separation of the data modeling, AI of fixing the data, fixing the holes, into the actually building the model. Then I'll build the case why AI is not performing. And in my example, for example, recently, the best AI models that we tried, of course, thousands of them, actually millions to be precise. And the best performance was around giving us 35% explainability of the patient behavior. Roughly speaking, of course, you can look at AUC, area under the curve. In this case, we look at R squared, we look at other characteristics, but basically, roughly speaking, R squared was 0.35. That was the best fit we could do. But with bringing the feedback from experts, trying to build, based on experts' opinion, smaller expert system, they completely changed the models and gave us success rate of over 90%. And here I'm going to give this example of when we think about our models we built in AI, Bayesian, boosting, neural nets, they're simple models, right? They're more like babies. And just think about that. Ask yourself, if you take 1,000 babies, can they replace one surgeon? And that's what we're trying to do. We're trying to explain expert opinion by putting all those ensemble models together by babies. And maybe it's possible, maybe not. Now, I talked briefly about disease progression. And here it comes not only from CT scans. It comes not only from measuring the tumors, but also if you look at the data, what you see, patients start going more often to the physician. There are more phone calls, there are ER visits. Something's happening. Even before we get results, usually in good practice, of course, we need to do the test. But even before doing the test, by getting information about the pain levels, about information about the uncomfortable condition for the patient, about those visits, we can predict that something's happening. That's one thing. Going back to the challenges of the data, and this was extracts of my publication in the Journal of PMSA, Pharmaceutical Management Science Association, from earlier this year. It's when you look at the data we have, first shocker that actually hits us, that big chunk of data is missing. When we talk about different types of claims data, right, you might say, okay, we can get EMR from the given hospital, let's say MD Anderson, and they have 100% of the information of the data on their patients. My response to that would be, actually, it's not quite true. In reality, a lot of patients go into the other physicians, ophthalmologists, for example, and when coming back to the cardiologist or oncologist, this data never captured. Moreover, dentists, you'll be surprised, prescribe quite a lot of the heart medication, a lot of, let's say, rare disease medications by dentists, and often it's not captured in the EMR system unless nurse asks patients what they're taking. Again, and that sometimes comes separately from the EMR. But usually claims are standard. The best claims you can find in the industry captures about 30 to 40% of all the patients on the medical side, of course, all the patients in the country, and up to 80 to 90% of the oral medications. That's why you see there's what we call, there's an issue with the capture rates. We don't capture the whole information about the patient populations. Often we capture only RX prescription information about the patients. We don't see anything medical. We don't see diagnosis information. We don't see, that's why we need to build a model to explain that. And in this particular example, when we look about chemo versus radiation, and if the product is indicated as after chemo and radiation, and we want to build a model that understands patient progression, patient behavior, data often tells us this patient has only radiations, no chemo. If you take it to the FDA, it could be a huge lawsuit because physicians actually, it's not within the pathways. They're not recommended to do only radiation without the chemo. It should be CRT therapy. That's the standard treatment pathways. But data doesn't capture the second part because chemo is done in the local office or in the chemo infusion centers, while radiation done in the inpatient institution often that have the radiation capacity and captured in the EMR. Here you go. How we can model that? And I'll talk briefly about this particular example. And if you just look at the numbers, average claims capture 20% of hospital visits. We say we're missing 80%. 40% of medical, but 90% of oral prescriptions, which is quite disturbing. Now, going back to my example that AI is not performing on disease progression. First of all, if you just take the raw data as it is, put it in the mix, and assuming that those millions of baby models were built, going to predict, actually it does not. Moreover, the drivers that you see because of missing data, the model predicts that actually, like in this particular example, radiation does not even drive the disease progression. In reality, it's opposite, right? Why we do radiation? That's the first reason. The second reason is that every patient is unique. And here we train the models on the other patients, and they're different. Moreover, the differences might not be captured in the data, meaning that, and here that's what we see a lot, that many patients from data standpoint are identical to each other. In reality, when you start talking to the physicians, when you start talking to the experts, you see those patients are very different. It just data does not capture those differences. But if you have a predictors of those differences in the data, if you train on the smaller universe, which includes expert opinions, you might capture that. And the last but not least, what we don't see in the data is a missing clinical expertise. Just ask yourself, why physicians have to go to medical school to 6 years, have to do 4 years of pre-med, doing residency, doing oncology trainings, for example. It takes over a dozen years to get there. And there are a lot of interactions. Are we actually training model on that physician experience? No, we don't. We train the model on the patient cases. We never train the models on the textbooks, on the pathways, on the other cases, everything that the expert has in their minds. Basically, that's why I call it the baby, because model is uneducated. It will not pass, of course, Turing test. It will fail any medical exam. But we are trying to use it as predictor. You know, it's almost like we are doing something criminal here. But again, and one more just to add here is that also models see only part of patient history. Usually, how many years of observation we have in EMR? 2, 5 years, sometimes 10 years. But EMR claims patients change insurance companies. On average, patients stay 2 to 3 years with one insurer. Then whole history is deleted. Then patients go to other physicians, or physician offices change EMR systems pretty often. And we lose this data. The proposal here is really to, all right, can we just completely replace AI with HI, with human intelligence? That's the question kind of first leadership asks us. Why do we need AI if our experts can explain everything? Unfortunately, experts cannot process, let's say, thousands of patients, sometimes millions, when we talk about diabetes or cardiovascular diseases. Also, experts, they learn on some cases and their opinions are skewed, meaning that you ask 2 experts on the same case, you might have 2 different answers. Nevertheless, it's still helpful to use expert opinion to explain some particular patient pathways to train the model. Or give you feedback of what particular drivers you should use in the model and kind of embed them by hand. In some sense, basically, we are looking for the combination of the expert system with expert loop and the deep learning. Now, the challenge here that we encountered is that you need experts support to build expert system, not just one time. I still remember years ago, I think one of the shipbuilding company, they use expert system to build the large ships, almost like Titanic. And they realized that when they use experts only once to build expert system and don't actually share outputs of that expert system with the same or different experts later to tweak it, to modify it, to improve it, it might not work. That's why what we created a loop, meaning that you build expert system together with deep learning, for example. And just for a simple example, you basically allow your models to become smarter. You kind of embed them together. You almost allow your models from babies to graduate to the kindergarten. I don't think it's still a high school there. I don't think we're there yet. But we still have a bunch of kindergarten models that actually perform much better than the baby models. And in this particular example, performance, in case of, again, chemo and radiation, from mere 42% jumped to over 90%. First, of course, by modeling the missing gaps, saying that let's impose some probability. When you see only radiation or only chemo, in reality, 90% are chemo and radiations are together. You don't separate them for this particular condition. And that's what experts tell us. You see, if you don't know that, if you don't have expertise, model will never tell you what is missing there. That's why here, basically, we're using experts not only to build expert model and AI/ML predictive technique. Again, we use SGBoost, we use simple random forest, we try that, and here actually, probably you notice that many times, random forests are not stable. Every month you get new data, new patients, the whole segments might be catastrophically changing, and basically you have to go away from random forest there, within the expert system actually. In the same time, it's still, what works well is when experts helping you to fill the gaps in the data. You show them the case, you see that something might be missing there. Please let us know what might be missing. And here it's almost like playing Sherlock Holmes and Dr. Watson, trying to uncover who actually committed that crime, right? What part of data is missing? And then we can model that. We can basically build the AI model, first to fix this data based on expert opinion, and then, based on the fixed data, we built another AI model to predict patient progression, which is also based on some experts' feedback. Here, let me pause. Any questions? Actually, I promised to ask questions before. Sorry, my fault. Any questions you have so far? Yes, please, yes.
When you're talking about filling in the gap, are you literally, or can one literally substitute another feature that's suggested by expert opinion that was missing in the
Yes. Yes, it's here what I call it's synthetic data. Bayes create probabilistic data, saying that if data tells you that those patients have only chemo, in reality, 80% of them have radiation. That's why you add another marker saying with 80% probability, this patient had radiation. You see here what's interesting, you create some kind of weight-based data. It's almost like weighted graphs. When you have in graph theory, you put this graph is weight is 5, this is 3, this is 2. Here we don't have directionality, but in synthetic data, you have probabilities, meaning that it's almost like a fuzzy data. You use fuzzy logic there, that you run the models on the data that have either 100%, it means it was chemo for sure, or 80%, it was radiation. Yes?
Is the expert that's used the patient's clinician or the third-party expert?
Both. We usually start with the medical affairs, with medical team who are MDs internally. Sometimes even bring HEOR team. They are also very knowledgeable. In some cases, we had to go to the physicians who actually not treating physicians, but also many times we just go to the actually, I would say, work with the third-party companies to get patient charts. And then physicians explain you through the market research kind of face-to-face interview, either phone or even face-to-face, what's happening with this patient. They just walk you through the patient chart through each point that we're trying to enter into the model and explain what's happening there. Basically both. One thing I mentioned briefly before, it's about repetition, because really HI is a repetitive process. We cannot just bring it only once. Also here, what's interesting is that we try to build AI models that actually imitate experts, kind of almost artificial experts. Of course, it's impossible to explain the expert behavior, but what we can program is something very pragmatic. We can actually program the pathways. We can program the NCDA guidelines and different types of guidelines. Usually how guidelines work, right? There is actually, it's a tree algorithm. And I've been always surprised why we don't actually use those guidelines and program them into the AI systems, because they're created by experts and that's what physicians are supposed to do. Of course, often they don't follow the guidelines, but in some cases they do. That's why if you have a fuzzy guidelines, fuzzy those trees, we can actually embed them in our tree system, in the tree nets, in the random forest, random trees, and so on and so forth. It's almost kind of organically comes there. Yeah, I think that those are the main things. Any other questions? Any other thoughts? If any other questions come, I'm here going to be at the reception at 4 o'clock. And please, let's grab a beer and have a great discussion. Thank you so much.